Yeah, hi. Hi everyone. Am I audible and visible? Am I audible and visible to you all? If yes, then we'll start with our session. As always, there is always a lag. So I'm sure that you must be waiting. How are you all feeling? Perfect. So today here we are here to discuss the NEET PG Predictor series. And it is so surprising that the only thing that we cannot predict about NEET PG is when it is going to happen, how is it going to happen, what is that pattern of exam. So yeah, we planned it in a different way. We wanted to do a predictor series just before the exam, but now you have a predictor series well 2 months before your exam. And I hope your spirits are high and you're still feeling okay about this exam. All those things, these are humbug. Don't get too bogged down by this fact that exam is being postponed. Remember, this postponement is for everyone. So its advantages and disadvantages are for everyone. Even the rank one topper in India is thinking, "Arey yaar, kya ho gaya?" And somebody who is not prepared till now is also thinking, "Kya ho gaya?" Right? So don't think that you are alone in this boat and don't think you are the only person who is unlucky. Every year, every batch feels the same thing. It started with me when I was in 2012, the first exam that I gave. That was the first time they gave one of the toughest papers. And then in 2013, I had the first NEET exam. So I was a victim to the change in the pattern. Now that the pattern has been established, sometimes there was 300 questions, there were multiple day exam, and now you have 200 questions and you have a single day exam, and now we are fighting with the Supreme Court uh, in terms of that we cannot have exam in 2 sessions. And you won't believe it, in 2012 the first NEET that happened, there was no concept of an online exam, so they had very limited centers, and so we had a 21-day exam, both 20 all 21 days, two shift. So there were 42 sets of paper. Imagine what would the normalization process would be. And that was a 300 question paper. There were around 12,000 questions. And that is why even if you open some old textbooks of previous year question, you would never find 2012-13 paper, because it was just impossible to compile those papers. And yet things, they move on in a particular pace as far as our government is concerned and the people who are deciding is concerned. So that is not something which is in our hand. So we should not really pay attention to it, but we should put our focus where we want. And God has given us an opportunity to become better, to become more thorough, because most of the students who have studied well over the last 6-8 months are going to sit and re-revise and re-revise and re-revise. And that is what everybody should do. Okay. फ्लो कभी टूटता नहीं है, याद रखो. दिस इज नॉट द फर्स्ट टाइम दैट यू आर स्टडीइंग फॉर एन एग्जाम. दिस इज डेफिनेटली नॉट द लास्ट टाइम दैट यू आर स्टडीइंग फॉर एन एग्जाम. ये सब फ्लो एंड ऑल, ये सब आपके माइंड में है. अगर आप बोलोगे फ्लो टूट गया है, तो एग्जाम के एक दिन पहले भी फ्लो टूट सकता है. एंड इमेजिन व्हाट हैपेंड लास्ट ईयर, दैट यू वेंट टू द सेंटर and then in the night around 10:30 there was this thing that exam is postponed. You are still in a better place. You know 15 days before your actual exam that it has been postponed, and you also know within a week when the next date is. So I think it cannot get better than this. So I think we should put this behind us and we should start with the 15 questions that I wanted to discuss in this predictor series. And see, its name is predictor series. So what I thought of was, let's try to extrapolate what has been asked in the exam. So I've made a mixed bag of questions with concepts, some images, and just to try and understand how to approach the questions that have been asked in the exam and how to make the best of what is going to be asked, or the theme on which the examiner can ask you questions. Okay. So let's start with the first question. A 65-year-old semi-conscious male patient is brought to the emergency department after a road traffic accident. He has a GCS of 9 and is snoring with increased work of breathing. A nasopharyngeal airway is inserted for airway maintenance. Which of the following is most appropriate reason to choose a nasopharyngeal airway over an oropharyngeal airway in this scenario? So can you tell me what is the obvious advantage of a nasopharyngeal airway over a oropharyngeal airway in this patient? Does it prevent the risk of gastric aspiration of gastric contents? Is it a secure device? So remember, oropharyngeal airway, nasopharyngeal airway, face mask ventilation, bag mask ventilation, supraglottic airway device, they are all not secure. They are not secure because they do not prevent the risk of aspiration. So no. they do not prevent the risk of aspiration. It stimulates gag reflex less and is better tolerated in a semi-conscious patient. Now, nasopharyngeal airway, imagine it's like a Ryle's tube. Ryle's tube is something you can insert in the ward. Initially, the patient will cough, but eventually they get adjusted to it. Nasopharyngeal cavity has less gag reflex because your gag reflex, your glossopharyngeal nerve is predominantly around the what you can say the base of tonsil. So if you are not stimulating the base of tonsil, then the gag reflex, the chances of gag reflex is pretty less. So this sounds about right. It allows for endotracheal intubation through it. Can you intubate through nasopharyngeal airway? Not possible. So no. And it provides a definitive airway protection. Again, the same thing. No. So the correct answer is that it is better for semi-awake patients. So as compared to oropharyngeal airway, this is the advantage of a nasopharyngeal airway. Also the advantage is it can be used in patients with no teeth, or in patients with very loose teeth, or in patients where you want things to be done in the oral cavity. And so this is very important where you have semi-awake patients and you have patients where you don't want to initiate a gag reflex. All right. So that is an obvious advantage of a nasopharyngeal airway over a oropharyngeal airway. Let me ask you that if suppose they give you an image of a nasopharyngeal airway and they tell you to identify what device is it, and in one of the options in the exam they also give you a uncuffed endotracheal tube, what would you choose? What would you choose? They would also give you the uncuffed endotracheal tube. How would you differentiate between an uncuffed endotracheal tube and a nasopharyngeal airway? How would you differentiate between an uncuffed tube and a nasopharyngeal airway? So we know that a nasopharyngeal airway would have no markings, isn't it? It will have no markings. The tube has to be put to a particular depth, so it has markings in it. Now a tube is made up of PVC, which is usually transparent, while a nasopharyngeal airway is made up of silicon, which is opaque. So it is made up of silicon, which is opaque. What else? Now you use a endotracheal tube to ventilate the patient, and therefore you need to attach a umbu bag or a breathing circuit. So it needs to have a universal connector. You don't need nasopharyngeal airway because you don't actually ventilate the patient, so no connector. No connector, isn't it? So the three reasons for differentiating between a nasopharyngeal airway and oropharyngeal airway: nasopharyngeal airway has no markings, oropharyngeal tube or ET tube will have markings. It is opaque, ET tube will be transparent and no connector, while ET tube will have a universal connector. All right. Question number 2. So a 48-year-old male with a GB syndrome has been on mechanical ventilation for 2 weeks. The ICU team plans to transition to the tracheostomy tube. What is the most appropriate rationale for switching for a tracheostomy tube in this case? Now we talk about airway management and we talk about all the things related to airway management, and tracheostomy is a part of airway management. Can you tell me what is the importance of tracheostomy? What is the importance of tracheostomy? It is used for long-term ventilation. It is used for long-term ventilation because it reduces the dead space and therefore it reduces the work of breathing. So does it provide better humidification? No, it doesn't provide better or worse humidification, because humidification is a feature of the upper airway. Your nasopharyngeal, oropharyngeal cavity, it naturally humidifies the air that you are taking, which is bypassed in both endotracheal tube as well as tracheostomy tube. So it has not an advantage of better humidification. Will they eliminate the need of mechanical ventilation? No. Your tube doesn't eliminate. You mechanically ventilate the patient because of the pathology here, that is GB syndrome causing diaphragmatic paralysis. So that is also not true. They reduce airway resistance and improve better patient comfort and improve patient comfort in mechanical ventilation. Yes. See, track is here. All your reflexes are here. Your gag reflex, your cuff reflex, everything is here. Now, if you put a tube here, then it becomes very, very easy for the patient. Dead space has decreased, work of breathing has decreased. No measurable coughing reflex, not much. And you can maintain a very good oral hygiene. The patient can feel better, and on long-term ventilation, it is easier because the chances of your tube kinking, crusting, getting stenosed is lesser with a tracheostomy tube. So this sounds about right. And they prevent nosocomial pneumonia completely. No. Nosocomial pneumonia can happen to any patient who is having an artificial airway. Doesn't matter that it is a nasopharyngeal airway, oropharyngeal airway, endotracheal tube, or even tracheostomy tube. But it does reduce airway resistance and improves patient comfort. All right. So that is tracheostomy tube. Now, if I ask you, of all the airway devices, which devices are secure devices? What do you mean by a secure airway device? Which devices are a secure airway devices? What do you mean by a secure airway device? What do you mean by a secure airway device? Secure is that prevents the risk of aspiration. Now, which device will prevent the risk of aspiration? Which device will prevent the risk of this aspiration? Any device with a cuff that is inflated in the trachea, because that is what securing the airway means, that your trachea is sealed, so it will not take any component from outside, right? And the only two devices which are secure are cuffed endotracheal tube and cuffed tracheostomy tube. Cuffed endotracheal tube and cuffed tracheostomy tube. These are the only two devices that are secure. Rest, all the other devices cannot be called as secure. Cannot be called as secure. All right. So far, so good. You guys are with me? Are you following what we are doing? We are, one, discussing the question that we got. Two, we are discussing some topics around that question to make it easy. Okay. To make it easy, to extend our learning, Now, during an emergency intubation attempt in a 30-year-old trauma patient, the anesthetist encounters a Cormack-Lihany grade 3. The assistant is asked to apply burp maneuver. Which of the following best describes the effect of this maneuver? Without looking at the option, can you tell me what is burp maneuver? Can you tell me what is burp maneuver? What is burp? What is burp maneuver? The name only tells you backward, upward, rightward pressure, burp maneuver. Where do you put this pressure? Do you put it on cricoid cartilage? When you push cricoid cartilage, what is that called as versus what is burp? So if you put a pressure on cricoid cartilage, it is called as cricoid pressure or Sellick's maneuver. But when you put the pressure on thyroid cartilage from outside, it is called as burp maneuver. So remember, there are two maneuvers. When you put the pressure on thyroid cartilage, it is called as burp maneuver. And when you put the pressure on cricoid cartilage, then it is called as Sellick's maneuver. Then it is called as Sellick's maneuver. Okay. So thyroid cartilage, burp maneuver, cricoid cartilage, Sellick's maneuver. I'm integrating things for you. This is often a point of confusion. This is cricoid, the lowermost. You put pressure in cricoid cartilage during RSI to prevent the aspiration. Prevent aspiration. How? When you put a downward pressure on the cricoid cartilage, it blocks the upper end of esophagus. What it does? It blocks the upper end of esophagus. Okay? But when you are not able to get a good laryngoscopic view, that is Cormack-Lihani grade 3 and 4, then you can always shift the larynx towards you by giving a backwards, upwards, rightward pressure. So this is your thyroid, backward, upward, rightward pressure, back upright, back upright. This improves your visualization of vocal cords during intubation. Does it move the larynx posteriorly to improve alignment? Does it have anything to do with alignment? No. Does it enhance laryngoscopy by externally compressing the trachea? Can you compress trachea externally? No, because anterior tracheal rings are cartilaginous, so you cannot compress trachea externally. Brings the glottis into a better view by manipulating the thyroid cartilage backward, upward and to the right, kind of very obvious, and prevents aspiration during laryngoscopy. Prevents aspiration during laryngoscopy. What prevents aspiration during laryngoscopy? Cricoid pressure or Sellick's maneuver. Cricoid pressure or Sellick's maneuver. Cricoid pressure or Sellick's maneuver. Understood? So two pressures, burp, cricoid, burp on thyroid improves laryngoscopy, cricoid on cricoid prevents the risk of aspiration. Understood? Prevents the risk of aspiration. So far so good. How are you guys feeling about it? Are they conceptual enough? The idea of predictor series is not just that you should know the question and the answer. The idea of a predictor series is that you should look at the concepts carefully and then try and analyze things. Okay? Understood? So a 40-year-old patient requires manual ventilation. In the emergency department, the junior resident connects the self-inflating bag but forgets to attach the reservoir bag. Which of the following best describes the consequence of this omission in a manual resuscitator device? Manual resuscitator device. So the patient cannot be ventilated at all. Room air will be delivered instead of higher FiO2. Positive pressure ventilation will not be possible. And one-way valve will fail to function properly. So basically, if you know the structure and the function of the AMBU bag or manual resuscitator, then you will be able to answer this question very easily. You are not attaching reservoir bag. What are you not attaching? Reservoir bag. What is the function of reservoir bag? It is the reservoir bag that stores the oxygen. So when you press the bag, the main bag, then it sucks the oxygen from the reservoir bag and delivers a higher FiO2. But otherwise, if you don't have a reservoir bag, you don't attach oxygen to it, then doesn't mean you cannot use an AMBU bag. In fact, AMBU bag is used in the EMS, emergency medical services, for the same thing. Even if you don't have a oxygen source, you can still keep ventilating with 21% oxygen. So the patient will be ventilated, positive pressure can be given, and one-way valve will not fail. What will happen is room air will be delivered instead of higher FiO2. Room air will be delivered instead of higher FiO2. Okay? Room air will be delivered instead of higher FiO2. Is it clear? Is it clear? Let's look at AMBU bag. And what is that you know about AMBU bag? AMBU bag is basically, AMBU is now the name of the company. You call it a manual resuscitator. Or artificial resuscitator. Now, when you attach a reservoir bag, the maximum FiO2 that you can deliver is, can you tell me what is the maximum FiO2 that you can deliver using an AMBU bag? Can you tell me what is the maximum FiO2 that you can deliver using an ambu bag? Yes, 100% oxygen. 100% oxygen. That is only because of the reservoir bag. Now, this last year NEET question, they gave the image of a manual resuscitator, pointed an arrow towards a part and asked what is the opening pressure of that particular part. That is a pressure relief valve. And it is mostly seen in pediatric manual resuscitators, and this pressure relief valve opens at 30 to 40 centimeters of water. This pressure relief valve opens at 30 to 40 centimeters of water. What does it, when does it open? 30 to 40 centimeters of water. That is very simple. More than 40 centimeters of water ventilating pressures are associated with barotrauma. So it only makes sense that your ventilating pressures are lesser than that. Your ventilating pressures are lesser than that. Okay? Understood? Everybody? Okay? Let's move on. A 70-year-old patient undergoing elective hernia surgery under general anesthesia being ventilated via second generation LMA. Which of the following best differentiates a second generation LMA from a first generation LMA? Again, conceptual question. Tell me, what is the difference between a first and a second generation LMA? What is the difference between a first and a second generation LMA? What is the difference between a first and a second generation LMA? So first generation LMAs are simple ventilating tubes. When you add a gastric drain port to the existing first generation LMA, you improve the margin of safety by causing the decompression of stomach and contents to come out using that port. So second generation LMA have better margin of safety against aspiration. Doesn't mean they are secure. So made of silicon and reusable. It could be a first generation second. See, LMA classic is made up of silicon reusable. LMA Pro Seal second generation made up of silicon reusable. So it's not like first and second is reusable. Depending on the material, it can be reusable. Having inflatable cuff for airway seal, both have it. Pauses a gastric drain tube to reduce risk of aspiration, yes. Can be used for endotracheal intubation in all cases, no. Can you tell me which airway device, which airway or LMA, laryngeal mask airway, can be used for intubation? Which LMA can be used for intubation? Can you tell me which laryngeal mask airway can be used for intubation? Can be used for intubation. Is there a laryngeal mask airway through which you can endotracheally intubate the patient without using laryngoscopy? That is the catch. Without using laryngoscopy, can you do that? Can you do that? Yes, that is called as LMA fast track. LMA fast track, also called as ILMA, intubating LMA, which is a special type of LMA, which is used to intubate trachea, Okay? Now tell me, what is the generation to which LMA fast track belong? What is the generation to which LMA fast track belong? Is it first generation, second generation, third generation, fourth generation? First, second, third, fourth. What is the generation to which LMA fast track belong? It doesn't belong to any generation. That is the correct answer. This is a special LMA. Special LMA. Special LMA. because it is per se not used for ventilation, and therefore you can't classify it as first or second generation. It is basically used for intubation. Basically used for intubation. Okay. Let's come to question number 6. Let's come to question number 6. A 55-year-old man collapses suddenly in a shopping mall. A bystander calls emergency services and starts CPR immediately. Which of the following correctly represents the adult out of hospital chain of survival as per latest AHA guidelines? Rapid defib, early CPR, advanced care, activation of EMS, post cardiac arrest care, early CPR, post cardiac arrest care, recognition and EMS, high quality CPR, defib, advanced care, post cardiac arrest care, and activation of EMS, transport to hospital, CPR. What do you want to do? So it is very straightforward. Recognition and activation of emergency response system, high quality CPR, defibrillation, advanced care, and post cardiac arrest care. There is also, these are 5 links in the chain of survival. 1, 2, 3, 4, 5. There is a 6th chain that has been added in the 2020 update. Do you know what is that 6th link in the chain of survival? Do you know what is that 6th link in the chain of survival? Yes. What has been added is recovery, which was asked in FMG last year. That has been added as the 6th chain link in the chain of survival. Now this is outside hospital cardiac arrest. What is different between outside hospital and in hospital cardiac arrest? What is the difference between outside hospital and in hospital cardiac arrest? What is the difference between outside hospital and in hospital cardiac arrest? See, in hospital, you have a very good idea which patients are going to get cardiac arrest, isn't it? High risk patients in CCU, SDU, ICU. So the idea is to recognize early and prevent. So the first step in hospital chain of survival is to recognize early and prevent. Then once the cardiac arrest has happened, then you call for help, that is activate EMS. Then you will start CPR and defibrillate the patient. Right? Now, what you are going to do in the hospital is what is called as advanced resuscitation. So you will directly shift from here to post cardiac arrest care. Nobody else is going to come and help you. And then recovery. And then recovery. So these are the 6 steps in hospital cardiac arrest. In hospital cardiac arrest, right? So the difference is you add one chain of prevention and you remove the chain for advanced cardiac life support, because you are going to be doing advanced cardiac life support. Okay? Question number 7. During a BLS course, a medical student asks, what defines high quality CPR? Which of the following is not recommended component of a high quality chest compression for an adult? बहुत कॉमन क्वेश्चन होता है, सर करना कैसे है, उसी पे क्वेश्चन बना दिया. Can you tell me the 5 do's and 5 don'ts of high quality CPR for a BLS provider? 5 do's and 5 don'ts of high quality CPR for a BLS provider. So 5 do's are chest compression rate, which is 100 to 120 per minute. That means not less than 100, not more than 120. Second is the depth, that is at least 2 inches. That means not less than 2, not more than 2.4 inches. Then third is allow adequate chest recoil. That means do not lean on the chest between compression. You have to come up and your palms should actually move above the patient. So you do not have to lean on the chest between compressions. That is your third. Then fourth is adequate ventilation. That means for every 30 compressions, you have to give 2 breaths. Do not over ventilate the patient. And last is, so you have adequate chest, minimize pauses in the compression. Minimize pauses in the compression. That means do not stop the compressions for more than 10 seconds. So at least 2 inches. Is it true? Yes. Allow full recoil. Is it true? Yes. Compression rate 60 to 80. False. Minimize compressions. True. This is one of the most important tables asked to you in the exam. It is like a sure shot question for you in the exam. This is a sure shot question for you in the exam. 100%. If at all they give a question of CPR, they will give it 99% only from these 5 do's and don'ts. Okay, very good. I am very happy. All of you are giving amazing answers. है ना? एकदम बढ़िया. Now, which of the following statements correctly differentiates the pediatric from adult BLS CPR technique? Which of the following statements correctly differentiates the pediatric from adult basic life support CPR techniques? So pediatric chest compression should be 5 to 6 centimeter deep regardless of age. For a single rescuer, the compression ventilation ratio is 30:2 for both adult and children. 2 thumb encircling technique is used for chest compression in adult CPR, and defibrillation in infant requires adult size pads only. Adult size pads only. What do you think is the right answer? What do you think is the right answer? Perfect. The answer is B, that yes, for a single rescuer, the compression to ventilation ratio is 30:2 for both adult and children. That means when there are more than one rescuer or 2 or more rescuer, then the compression to ventilation ratio will change. So let's look at difference between adult and pediatric CPR. Difference in adult and pediatric CPR. So there are 5 points of difference between an adult and a pediatric CPR. Let's start with the first. Activation of emergency response system. So in an adult, you always first activate the emergency response system. You first call for help, then you give the CPR. So suppose you are there, somebody collapses and you have help. So you will tell somebody to call for help and you will start CPR. Suppose you are alone with the victim but you have a phone. So you will first take out the phone, call for help, then resume the CPR. And suppose you are alone with the victim and without a phone, then you will leave the victim to go call for help. But if you are in a situation where there is a pediatric victim and you have not witnessed the collapse, see, if you have witnessed the collapse, then you will do exactly like what you do in adult. But if you have not witnessed the collapse, so you enter a scenario where the child was already collapsed and now you don't have help, you don't have someone to tell to call an EMS, then you will first do 2 minutes of CPR, then leave the victim to go call for help. Can you tell me the reason why this change in the guideline for a pediatric patient as compared to an adult patient? Why are we doing this? Why this little nudge? Because most common cause of cardiac arrest in a pediatric patient are respiratory in origin as compared to cardiac. In adult, because cardiac is the reason for this cardiac arrest, cardiac cause. So defibrillation is your priority because that will revert the back rhythm to the synchronized rhythm. But in pediatric patient, the reason is respiratory in origin. Most probably a foreign body choking, or most probably an apnea, or most probably a crowd, whatever. So because it is respiratory, so defibrillation takes a lesser priority. So at that point of time, it would be prudent that if you give 2 minutes of CPR, you are potentially saving the life of the baby. Okay. So in a pediatric patient, when you have unwitnessed collapse, you will always first do 2 minutes of CPR, then leave the victim to go call for help. Once you start the CPR, compression to ventilation ratio without advanced airway, BLS, with advanced airway, ACLS. So in BLS, in adult, irrespective of number of people, 30:2. With advanced airway, irrespective of number of people, 1 every 6 seconds. But again, in a pediatric patient, when 2 or more rescuer, you will increase the percentage of the breaths as compared to the compression. So when you have 30:2, 30 compressions per 2 breaths. Now you will do 15:2, matlab 30 compressions per 4 breaths, 15 compressions per 2 breaths. So because the causes are respiratory, so your focus will shift to respiratory only when you are 2 or more, because then you don't waste time between compression and ventilation. So you take this liberty only when you are 2 or more. And in patients with advanced airway, you will go for 1 breath every 2 to 3 seconds. Depth of compression, obviously, if it is an adult, it is 2 to 2.4 inches, that is 5 to 6 centimeters. But if it is a pediatric, then if it is a child, about 2 inches, if it is an infant, about 1.5 inches. Hand placement, lower half of sternum for an adult. If it is an infant, 1 rescuer, you will use a 2-finger technique. If you are 2 rescuer, you will use a 2-thumb encircling technique. Okay. Okay. Done. Perfect. Are you guys happy? Should we move on? Should we move on? So question number 9. During advanced cardiac life support scenario, a 70 kg adult is in asystole. The team administers adrenaline. What is the correct dose and interval for adrenaline administration during adult CPR? So one of the important questions in CPR is the dosing of adrenaline. So tell me, what is your agent of choice for the treatment of CPR? It is adrenaline. What is your agent of choice? Adrenaline. Now, how to give adrenaline? How to give it? So let's first talk about the dose of adrenaline. So dose for an adult is always 1 milligram. Dose for an adult is always 1 milligram. What would be the dilution? What would be the dilution? So what you normally get in the market is a 1 in 1000 dilution, that is 1 milligram per ml. So I'm making you understand this thing, that when you have a dose 1 milligram per ml, you call it 1 in 1000 dilution. 1 in 1000 dilution. Now, it is the dilution that you never use for intravenous use. It is too strong. So you always dilute it to 0.1 milligram per ml, which is now 1 in 10,000. So when you take 1 ml of 1 milligram per ml adrenaline and dilute it till 10 ml, now the effective dilution is 0.1 milligram per ml, that is 1 in 10,000. This is the dilution that you use for CPR. This is the dilution that you use for CPR. What is the frequency? After how much time will you repeat? 3 to 5 minutes. And what is the max number of times you can repeat? Unlimited. as many number of times as you want. Unlimited. This is how you should remember adrenaline. Adult 1 milligram, dilution 1 milligram per ml is 1 in 1000. This you just for understanding purpose. देते नहीं है. देते क्या है? 0.1 milligram per ml, 1 in 10,000. Frequency 3 to 5 minutes. Number of times unlimited. IV. This is IV or IO. Intravenous or intraosseous. But suppose you don't have a, so endotracheally you will use undiluted, but undiluted in the sense you will use 1 in 1000, 2 to 2.5 milligrams, and just for better delivery dilute in 10 ml, and you will inject it, you will inject it endotracheally. So 2 to 2.5 times the dose. So it will become 2 to 2.5 milligram. You just dilute it in 10 ml so that there is a better delivery. There is a better delivery. All right. So the correct answer is 1 milligram IV, 3 to 5 minutes. This is the dosing of adrenaline. Now you can't get confused, because if adult is 1 milligram total dose and you consider somebody as a 70 kg adult, then automatically the dosing will become 0.01 mg per kg. 0.01 mg per kg, and maximum dose cannot go beyond 1 milligram. Maximum dose cannot go beyond 1 milligram. Okay? So it is 0.1 mg per kg or 0.1 ml per kg of 1 in 10,000. So बच्चा हो या बड़ा हो, बात वही हो जाती है. ठीक है? No, in ET tube, you can't call it a dose, because first is 1 in 1000 का 2.5 milligram ले लेंगे, and then just for better delivery dilute it in 10 ml. So you can't call it 1 in 10,000 also. When you take 1 ml and dilute till 10 ml, it is 1 in 10,000. But here you are not taking 1 milligram and diluting it in 10 ml. You are taking 2.5 milligram and just using it in 2.5 time dosing. So you can't call it 1 in 10,000. So remember, 2 to 2.5 milligram, 1 in 1000, dilute in 10 ml and push endotracheally. Okay. Now a 30-year-old unconscious patient with normal breathing and a palpable pulse is being managed in a public park. While waiting for EMS, which of the following is the correct next step? Which of the following is the correct next step? Start compression, administer rescue breaths, leave the patient supine, and monitor and turn the patient into recovery or lateral position. What do you think you are going to do? What do you think you are going to do? Is it a unique situation? Yes. Unconscious with normal breathing and a palpable pulse. So if breathing present, pulse present, is it cardiac arrest? Is it cardiac arrest? No. So if it is not cardiac arrest, will you give CPR? No. So see, what happens is when you have a collapsed victim, then what is your order of steps? When you have a collapsed victim, what is your order of steps? The first is always to, can anybody tell me? What is the first step? What is the first step? In a collapsed victim, what is the first step? Yes. First step is to keep airway clear. You will directly go for airway. You are not even a doctor. You are in a park. You are in a mall. You are by the side of a train in the station or on a bus stand. And you will directly go and clear the airway. और अगर पेशेंट को सीजर आ रहा होगा और आपने एयरवे क्लियर करने के लिए यू पुट योर फिंगर इन एंड द पेशेंट बाइट्स योर फिंगर, वेरीफाई सीन सेफ्टी. दूसरों की जय से पहले खुद को जय करें, हमको मन की शक्ति देना, मन विजय करें. That is what you have to do. Before you go on to help somebody, first see whether it is safe for you to approach that situation or not. So, दूसरों की जय से पहले खुद को जय करें. First step is verify scene safety. Once the scene is safe and you can approach it, then the next step would be to assess responsiveness. You will tap on the shoulder. Hello, sir. Hello, ma'am. Are you okay? Are you okay? Assess responsiveness. Once the patient is unresponsive, then you will call for help. So you will tell somebody to call for help and then check for pulse and breathing. Simultaneously, not more than 10 seconds. Simultaneously, not more than 10 seconds. Now, here comes the scenario. You will have three scenario: pulse present, breathing present, pulse present, breathing absent. Third is pulse absent, breathing absent. ऐसा हो सकता है क्या? Pulse absent, breathing present? नहीं. Pulse नहीं मतलब cardiac arrest. Cardiac arrest में breathing नहीं हो सकती. What will you do? Pulse present, breathing present. You will give recovery position. Unconscious patient who is having pulse and breathing. That means some other cause of getting unconscious. So you will simply give them the safest position, that is recovery position. Recovery position. Turn on one side, one hand under the chin, another straight, one leg over another, safest position. Pulse present, no breathing, rescue breaths. Pulse present, no breathing, rescue breaths. No pulse, no breathing, start CPR. Start CPR. All right. No pulse, no breathing, start CPR. So this is the steps. And on the fourth step, these are the three possibilities. Understood? So remember these steps. Lot of questions get asked on the chronology of how you do things. From the chronology of how you do things. Understood? Is it clear? Am I making some sense? Are you understanding what we are trying to do here? Same goes with foreign body obstruction. Same goes with foreign body obstruction. How would you know there is a foreign body obstruction? So foreign body obstruction can either be partial or it could be complete. Partial or complete. How would you differentiate? Partial, vocalizing. Patient is able to vocalize. If the patient doesn't vocalize, no sound, or the patient gives a universal choking sign, then that is a complete foreign body obstruction. Complete foreign body obstruction. Significance of recovery position, same. When the patient is unconscious but having pulse and breathing present, that means cardiac arrest नहीं है, तो chest compression नहीं करना है. तो your next criteria is you prevent aspiration. तो जब आपने turn कर दिया एक side में, even if the patient regurgitate vomits, it is going to go out. ठीक? Now you only treat complete obstruction. You only treat complete obstruction. So if there is complete airway obstruction, then the next step would be responsiveness. Person is responsive. The person is unresponsive. Person is responsive, unresponsive. Now, if the person is responsive, then see whether the person is an adult or whether you know, or a child. If it is an adult, you will do Heimlich's maneuver. If it is child, less than 1 year, then 5 back blows, 5 chest compressions. Five back blows, 5 chest compressions. If there is an unresponsive victim who has suffered a foreign body obstruction, what will you do? Yes, CPR. That means that foreign body must have caused cardiac arrest. And at this point, your priority is to save the heart. Your priority is to save the heart. Okay? Your priority is to save the heart. So this is a flow chart for foreign body obstruction. पार्शियल है, कुछ नहीं करेंगे. कंप्लीट है तो देखेंगे रेस्पॉन्सिव अनरेस्पॉन्सिव है. रेस्पॉन्सिव है तो एडल्ट में हाइमलिक करेंगे. लेस देन 1 ईयर में 5 ब्लैक बूस्ट चेस्ट कंप्रेशन करेंगे. अनरेस्पॉन्सिव है तो सीपीआर करेंगे. ओके. क्वेश्चन नंबर 11. A 30-year-old male undergoes a forearm tendon repair under IVRA using lignocaine 10 minutes after drug administration. He complains of dizziness and perioral numbness. Which of the following is the likely cause? Dizziness, perioral numbness. You have used IVRA. What is IVRA? What is IVRA? What is this technique of local anesthesia called as intravenous regional anesthesia, also called as Bayer's block. Also called as Bayer's block. Intravenous regional anesthesia, also called as Bayer's block. Bayer's block, where you inject a local anesthetic intravenously. So if you are injecting intravenously and somebody is complaining of dizziness and perioral numbness, it points towards allergy. No. Systemic absorption due to tourniquet failure? Yes. Excessive sedation? No. Delayed onset? No. Tourniquet fail हो गया, आपको deposit करना था in the limb after tourniquet inflation. Now it has gone into systemic circulation, causing CNS last. This is a typical CNS last. Local anesthetic systemic toxicity. CNS last. Local anesthetic systemic toxicity. It has caused CNS last. ठीक है? All right. Yes. Now, 2 things to remember. Agent of choice for IVRA, Prelocaine is preferred. Since it is not available in India, you also need to remember lignocaine. Margin of safety is high. Which agent has to be completely contraindicated? Bupivacaine. Which agent has to be completely contraindicated? Bupivacaine. Complete contraindication, bupivacaine. It is actually the least skilled technique. कुछ करना ही नहीं होता है. जिसमें लेना है उसमें IV लाइन लगा के टूर्निकेट इन्फ्लेट करके ड्रग दे दो. One of the easiest regional anesthetic technique. Block देना is difficult. Brachial plexus block, wrist block, elbow block, all those things are difficult. Okay. Question number 12. A 19-year-old male for elective hernia surgery repair under general anesthesia develops tachycardia, rising EtCO2, muscle rigidity and hyperthermia. Which of the following agent is most likely responsible for triggering this reaction? Most likely responsible for triggering this reaction. What do you think has happened? Can you tell me the diagnosis? Can you tell me the diagnosis? Malignant hyperthermia. Very good. Tachy, rising EtCO2, rigidity, hyperthermia points towards MH. We know MH is caused by either scoline or volatile anesthetic agents. Let's look for them in the option. Is propofol a scoline volatile? No. Midaz? No. Nitrous? No. Why? Nitrous is a pure gas, and nitrous and xenon do not cause malignant hyperthermia. The correct answer here is sevoflurane. Sevoflurane. What is your drug of choice for malignant hyperthermia? Drug of choice for malignant hyperthermia. Can you tell me drug of choice for malignant hyperthermia? Agent of choice for treatment, dandrolin. Agent of choice for treatment, dandrolin. All right. A 60-year-old patient with ARDS is on mechanical ventilation. The intensivist increases the PEEP from 5 to 10 centimeters of water. What is the primary physiological response for increasing PEEP in this setting? Primary physiological response rationale for increasing PEEP in this setting. Why are we increasing PEEP? What is the rationale of increasing PEEP? What is PEEP? सबसे पहले तो देखो ये PEEP क्या होता है? PEEP is positive end expiratory pressure. That is when you apply a positive pressure at the end of expiration. What it does, creates a back channel pressure which keeps the alveoli open. Which keeps the alveoli open. Right? Now, when you are giving this positive end expiratory pressure in an intubated person, you call it PEEP. Now, PEEP in non-intubated person would be called as PEEP in a non-intubated person would be called as CPAP, which is weird. It's the same thing. Why call it two different things? But you call it continuous positive airway pressure when it is done in a non-intubated person. Okay? And what it does it increase the respiratory rate? No. Does it decrease CO2 production? No. Prevent alveolar collapse and improve oxygenation? Yes. And reduce oxygen toxicity? No. Not directly. Not directly, but yes. If you use adequate PEEP, then with lesser FiO2s, you will get better oxygenation. So yes, should decrease the risk of oxygen toxicity, but not directly. Not directly. All right. So far, so good. Question number 14. So, a 45-year-old female undergoing laparoscopic cholecystectomy receives rocuronium for neuromuscular blockade. At the end of the surgery, the anesthesiologist decides to reverse the block rapidly. Which of the following agents will be most appropriate and why? Most appropriate and why? 45-year-old laparoscopic cholecystectomy receiving rocuronium for neuromuscular block. You want rapid reversal. Will neostigmine work faster? Atropine to reverse bradycardia, Sugammadex due to specific encapsulation, and naloxone. Straightforward. Immediate reversal of ROC and VEC. ROC and VEC. Immediate reversal of ROC and VEC. ROC and VEC will be done by Sugammadex. Immediate reversal of ROC and VEC by Sugammadex. Okay. You are monitoring a patient under general anesthesia with a neuromuscular blocking agent. The capnographic waveform shown below is recorded intraoperatively. What is the most likely explanation of the pattern seen in the capnogram? Can you tell me? What is the most likely pattern? What is the most likely reason for this pattern? Most likely reason for this pattern. Yes, this is a typical curare notch. that is first spontaneous breath under muscle relaxation. First spontaneous breath under muscle relaxation. Is it due to incomplete exhalation due to bronchospasm? No. Rebreathing of CO2? No. Inadequate neuromuscular block leading to diaphragmatic movement? Yes. And patient is developing malignant hyperthermia? No. But can you tell me A, B और D में कैसा कैप्नोग्राफ दिखेगा? A में कैसा, B में कैसा और D में कैसा? Interesting ना? They are also possibilities under anesthesia. So A में कैसा दिखेगा? How would you see in bronchospasm? How would you see in bronchospasm? Shark fin appearance like this. Shark fin appearance. Very good. How would it look in B? Rebreathing. Rebreathing. कैसा दिखेगा? Graph not touching the baseline. Graph not touching the baseline. D. Patient developing malignant hyperthermia. What will you see? You will see sudden rise in EtCO2. Sudden and abrupt rise of EtCO2. Sudden and abrupt rise of EtCO2, isn't it? So we discussed all the 4 very commonly asked capnographic waveforms as well. Capnographic waveforms as well. Okay? Alright. So this is what I wanted to discuss in your NEET PG Predictor series. I hope you are feeling better now. And I hope you are realizing that it is just a matter of seeing the question. You have read everything. You remember everything. It is just about applying. So next 2 months should be all about application. Revision, 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 revision is all what you need to get through this exam. Just keep your spirits high. If 1 or 2 days you don't want to read, that is also fine. You can take a break. That is not a problem. Okay. So all the very best. Thank you so much and God bless you.